Great, thank you. Okay, our last speaker from the field is Samson Saigilu. He was raised by traditional Maasai parents in a pastoral community in a village in southern Kenya. Samson holds a certificate in environmental health sciences from Kenya Medical Training College, a diploma in community health and HIV/AIDS management from Mount Kenya University, and a certificate in HIV testing and counseling. Samson currently works with the Ministry of Public Health and Sanitation as a public health officer at a health center in southwestern Kenya. In July 2013, Samson was invited to participate in the Rotary International Kenya Smiles Oral Health Project. He is committed and passionate about improving the oral health status of children in the country, and most recently became the co-director of the Loitoitok. Okay, he can teach us how to say it. Project, oral health project, where he is responsible for project implementation and management in Kenya. And I've just gotten to know Samson this year since participating in Kenya Smiles last summer. And I would like to be honored to be one of his aunties as part of the project. Thank you.
Good morning, everyone. As Karen has told you, my name is Samson Saigilu from Kenya. Because of time, maybe I'll just go, through all the slides. I'll take you through my country. As you can see, Kenya is situated in Eastern Africa, the black part, and the equator divides the country roughly in two halves. Kenya is bordered by Somalia and Ethiopia, Sudan, Uganda, and Tanzania. The total population of Kenya is approximately 43 million. Kenya is famously known for several parks, the Amboseli National Park, the famous Masai Mara, where you can find the big five, the elephant, the rhino, the leopard, the lions, and the buffaloes. There's so many other animals, the giraffe, the crown cranes, the leopard, the hippos, and also the ostriches and the baboons. Kenya has 47 county governments. Each county is divided into districts. The district of Loitoitok, where we work, is located in south central Kenya, and it borders Tanzania and is on the slopes of Mount Kilimanjaro. Loitoitok has a total population of 95,430 people. My culture. I come from the famous Maasai community. They're famously known for so many activities like dancing. You see how they put their hairs. The Maasai elders, they're famously known also for jumping. They're still about our culture. She's my mother, Mary. Those are other members of our community. Those are girls in school, and also the women in the community too. The Maasai community are also known for herding. You see, the Maasai warriors are going for grazing with their spears because they might find lions on their way, and they have to kill it if they have to pray for the animals. Those are the main households. The women are the one who makes the households. The men are just there for providing food and other stuff. The main source, the main source of fuel, there is no electricity. There is no electricity, and the only thing that they use to make food is firewood. So that is how they carry from the field. They carry the fire from the field to home. And also there is no provision of water. There is no tap water. They have to collect the water from boreholes, and they use the donkeys to take the water home. family. That was me back 2002, when I was a very young boy. Yeah, this was on a wedding ceremony. He's my dad. I always dedicate everything that I do to my dad because my dad is visually impaired. And I always say, because he has brought me far, I always dedicate everything that I do to him. And I always say that may the vision of his heart replace the limitation of his eyes. He's my mom. She's my in-law and other family members. Still my family. Our home. Sorry. This is our household. These are the family cows. This was me grazing the goats. And this is our homestead too. My work, I work as a public health officer in Loitoktok, Kenya. And this is what I do. Here we conduct mass campaigns on trachoma. And we also have included now that we are also conducting mass campaigns on oral health education, immunization in communities, because these people are very far. So we have to travel for long distances to reach these people for immunization on measles, polio, pneumonia, and other infections. Yeah. We also conduct integrated management of acute malnutrition. We visit villages. We target younger children under 5, the pregnant women, and the lactating mothers. We also visit schools, conducting school health programs, deworming, oral health education. Here, we're immunizing tetanus for the reproductive age women. There, we are also conducting trachoma mass campaigns. My school, I also go to school on a weekend basis. I'm taking a bachelor's degree in public health. Our health traditions. The Maasai are famously known for extraction of the lower 2 incisors, the lower central incisors, you see. And that poses a risk because it's the older men and the women who perform this. And they will use one iron knife for like 10 children. And this can increase the risk of HIV infection. Because using the iron knife for more than 10 children and you don't know their HIV status, it poses a risk. Maybe some people will ask me, what is the reason behind removing the central incisors? Longer time ago in Maasai communities or even in those remote villages, the Maasai did not have health facilities. They did not access health care. So they will remove the teeth so that when someone is sick, when she's having locked jaws, they can pass milk inside here so that the person cannot stay hungry when they are sick. Oh. So it was since time immemorial. It has been a long time, sorry. Our health tradition, hygiene. In those communities, there is nowhere you can buy a toothbrush or a toothpaste. So what they use, they make chew sticks. Like a branch of a tree, you just cut a twig and you use it to make a toothbrush. And this is what this old man is doing here. And also, they use herbs to brush their teeth. And charcoal too. And the charcoal, you see the charcoal is used for preservation of milk in our Maasai communities. I'll get to there when I show you a gourd that they use to store milk. So the charcoal that is being used to preserve the milk is used also for brushing their teeth. The traditional diet. They're famously known for, since they are herders, they take a lot of meat. Ugali, which is a maize flour, that is also meat. Blood. They use a bleeding arrow. They use a bleeding arrow when the cow is still alive, and they will get a mixture of blood and milk and take together. And it has been done for a very long time. since they say that it has a lot of nutritional value, taking cow blood. You see, again, these are gourds. They use the charcoal to preserve milk. They would make a brush and brush inside with the charcoal, and the charcoal that is being used, when you pour the charcoal down now, you use to brush your teeth. So again, this is what they used to feed their children. They feed the goat. There is no, at some point, where in remote villages they are not bottled. This is how they milk their cows. A calf will come on this side sucking, and the ladies will milk the cow by the other side. Traditional diets and nutrition. There is a challenge here in these communities because in remote villages, people really don't go to the market and buy such foodstuffs. They will only go on a market day. You might find in remote villages, they only have an advantage of going to a market day once a week. So they can't really get access to such. Infants and toddlers. You see how they carry their children by the back. And on the other side, in front, they will carry a gourd that they use to feed the children, and another one on the other side, which they have water to feed the children too. And it's used for so many children. They use bottled or gourd milk. I've showed you previously. Also porridge is the most staple food because out of the maize flour that they make ugali, they also use the same to make porridge. Tea with milk and sugar and water. So here, the modern nutrition risks. As you can see here, since the Maasai community are known for making beads, a mother, so that the kid will not disturb her when she's making the beads, she will give the kid a lollipop so that she can keep quiet and continue making the beads. And also these are biscuits. And this is another picture we took in a school. The school, the school pupils were participating in a games competition. And since they are tired and they've won a game, they are being rewarded with sodas and bread. You see? So many of them. Oral health problems and challenges in Loitoktok. Number one is cultural and traditional practices and beliefs. That is where the point of removal of the lower central incisors come in. They believe it's out of beliefs and traditional practices. Herbal remedies, which are toxic. At some point, you might find the kids are so young and they want to brush their teeth, or they're even 10 years, and they just decide to get any chew stick, which can even turn to be toxic and affect their health. Lack of trust for the dentist. They believe that you better even go to a traditional healer and get your teeth removed than going to a dentist. Affordability of care. Communities near famous national parks are flooded with candies from tourists. The tourists, when they visit these Masai Manyatas and villages, they will go with a lot of sweets to reward the kids, so that their parents can get time to entertain them with the Maasai dances. There are also natural calamities like the drought and floods. At some point, access to care is a challenge because when it comes to drought, people move. The Maasai community are famously known for nomadic pastoralism. They move to places. They can even move to Tanzania. They can move to other countries with their livestock in search of passages and water, and also floods. It's also a challenge. Poverty, ignorance, and illiteracy. Illiteracy is really a challenge too, because people don't go to school. The kids don't go to school, so they don't even have a knowledge on any sort of oral health hygiene. The other challenge is in Loitoktok, with close to 96,000 people, we only have 2 dentists. And the dentist is only based in the district hospital. And the farthest station is even more than 150 kilometers away from the district hospital. And the 2 dentists don't work at the same time. They work on shift. And the whole district, out of the 96,000 people, they only have 1 dental chair. And the charges are not that high. But people, it's still a challenge because of distance. Again, even if people try to get to the dentist, they still face challenges. Prohibited distances over rough terrain, because transport is really a challenge. Lack of transport, the human-wildlife conflict in the bordering, in areas bordering the national park ecosystem. So people, when they try go access care, they can meet elephants, lions, and they have to go back home because they can't go through that area. Dental fluorosis. The Rift Valley, because we come from the Rift Valley, is still an active volcano region and with high fluoride content in the drinking water. So you see, since water is also very scarce, they, through donations from the government and other well-wishers, they drill boreholes. So the boreholes really have a lot of fluoride content, and that is what is causing fluorosis, dental fluorosis. That was me, my work with Kenya Smiles, educating oral health education. Kenya Smiles. Kenya Smiles is the project that really made me to have a passion of addressing oral health in my community. And they also work in Kenya, improving the oral health of children in Kenya through sustainable dental preventive care programs. That was me. That was Karen. Back last summer, Dr. Maureen Valley, Sheila. You see again, the other challenge again, you see, the hygiene and sanitation is very poor. You see flies, because the water is very scarce. The kids, even after eating food, they don't even wash their faces. So flies will come along. Sorry. The Loitoktok Oral Health Project design and overall overview. Before we started collecting data, we underwent so many phases, like the ethical committee and project proposal approval. And that was me and Dr. Maureen Valley. Investigators. There was a challenge in funding because we only had a primarily private funding. Kenya Smiles also, Rotary Club of Walnut Creek, volunteers. I'll get back to that. Guidance and mentorship. When we were starting our project, we started by project introduction to the community. 28 district public health facilities and 6 schools. Then we started by distribution and education to Kenya Smiles Toolkit to health facilities staff and school teachers. So we started moving around before. We supplied the oral health education toolkit and also the posters to mobilize people. Like you see, this one is in English. Some people will read, this is Maasai language, and that is Swahili. Community mobilization. Phase 3 is baseline assessment and education, whereby we visited 9 community locations, that are 9 health centers, and 4 schools for oral health education. We had 5 team members. That was myself, Dr. Valley, Johnny, some other volunteers from Kenya. Sorry. On phase 3, we really took a lot of activities. Like the first one, we started with consent and questionnaires, adult and older child, older and younger child, and mother interview. That's what we are doing there. Nutrition assessment. As you can see, we are taking child weight, height, and mark, the mid-upper arm circumference, to really assess the malnutrition status. The other thing we did is oral health assessment. That was Dr. Maureen Valley and Dr. Johnny conducting oral health examination for both the children and adults. The same? Mm-hmm. That was myself conducting oral health education in schools. And the reason as to why this is so important in Maasai communities, you know, people are illiterate. And we want to use the kids to pass the message home. We want to use the kids as ambassadors for the community. Because everything that the kids are being taught in school, because they don't see visitors all the time, they'll have to pass the message home. So that was the strategy behind that. And still also on the same, teaching them on the healthy and unhealthy foods, how to brush their teeth, oral health education. We gave them toothbrushes too, and toothpaste, and they were so happy. You see, even here, they even started brushing their teeth, because you see these kids, it's their first time to use a toothbrush. They've never used. They even started brushing their teeth when the toothbrush was still wrapped with the nylon paper, this way. So we had to really give them some oral health education points. When it comes to data finding, we visited 9 locations, and we collected. We had 736 total subjects. 218 subjects are under 13 years. The reason as to why we are concentrating with under 13 years, kids, the parents even don't know the ages of their children. So a mother can tell you that my kid is 4 years, but the kid is even 8 years. So that is why we really had to use up to 13 years. But we realized that 6% of the total children own a toothbrush and a toothpaste. And again, out of that 6%, those are kids along the highway. In remote villages, it's 0%. 87% have never seen a dentist out of the total kids. And out of the 13% remaining who have seen a dentist, the reason was for tooth extraction only. They don't visit a dentist for a dental exam or tooth filling. They just go there when they are ready for the tooth to be extracted. Our age cohort, we 0 to 6 years, 5.4% out of the total. 7 to 12 years, 20%, 20.2%. And so many adults really turned up because they're the most people who have dental problems here. Out of the 9 locations, for us, we were studying about the decay levels of children under 13 years. Decay levels, the red one, and average decay for the whole community. And when we were collecting this data, we had 3 things in mind. That we are trying to see how is the decay of the kids who are along the highway, who have access to candies and sweets, lollipops, and others. Again, we were also trying to access about those communities which are very close to national parks, because the tourists will bring a lot of candies. And again, the other one was those remote villages where people don't have access to a toothbrush. So we found like when you see here, this is along the highway. So many kids had tooth decay. And also, the adults or the whole population for that matter. But when you come here, this place is so near to the national park. So many kids had tooth decay because the tourists are giving them a lot of candies. Most of these from here are along the highway. You know the kids when they are being sent to a market to buy foodstuffs, the little amount of money they are given that is remaining, the change, they use to buy sweets and other foods that are not good for their teeth. Average tooth decay for the whole population against plaque index. You see, tooth decay is very high, and the plaque index is also very high here. But again, when you see, like, look at Ngong Narok, the tooth decay average percentage is very low, but the plaque index is very high. That shows that these people don't really brush their teeth. It's in those remote villages. Fluorosis levels. Normal is at 17%. But questionable is at 23%. That is how we are really doing that. Our thoughts for the future, activities and sustainable oral health programs. We want to introduce community outreaches and oral health integration programs in those communities. Number 2, integration of oral health and nutrition topics in antenatal, maternal, and child care programs, including management of acute malnutrition and exclusive practice of breastfeeding versus bottle feeding. Number 3, community cultural discussion and sensitization regarding lifestyles and behavior. Because in Maasai communities, people really respect the elders. So we want to use the elders and the cultural elders, the chiefs, to really call for a lot of oral health education. School oral health programs and clubs, since we say that the kids are going to be ambassadors of oral health. Training of oral health basics to teachers, nurses, public health, community health workers, and community health committees. Advocacy and enactment of community health laws and community-based strategies for oral disease control. Clinical and public health research. Mass campaign on anti-junky foods and use of cell phone technologies where people have phones, and also provision of dental camps. to end, Asholeng means thank you very much. It's a Maasai word that means thank you very much. We want to thank UC Berkeley, UC San Francisco, Health Roots, Dr. Karen, and Hildy Fong. And to me, I'll say on behalf of the Loitokto Oral Health Project, these are kids who have never gone to school, but they're still saying thank you for providing them with toothbrushes. I would like to say thank you very much to Karen. Thank you for giving us this opportunity. And we look forward to work with you sometime again. Again to Dr. Valley, Johnny, and Peter Henry. So many people, Sheila and his group, thank you very much. To me, I'm privileged. And it's my first time being in April, and you made it for me. Thank you very much.
Great. Thank you. Thank you, Samson, and another applause for all of our speakers. Thank you. You want to move your seats up here, and then let's take 5 minutes for comments from the audience. You want to move up a little closer here, and we can... Do we have microphones in the audience? If you have any comments or questions for any or all of our speakers. Any comments, questions? Yes, Luke.
Now that you have this kind of broad spectrum of audience attendees in front of you, what would be your biggest request to the community?
I think, one of the biggest challenge we have is how Doctoria says at the beginning, is to make an alignment. And also, sometimes people that lives in the United States has more power than we do in our countries. So you have the power to convince people here in the United States to have a better idea of what is happening in our countries. So I think if, the power of one, like Dr. Karen did, with us in our country, and if we can have more people like her committed, to spread the voice out of, what is happening in our countries, it will help a lot.
The same questions? Is this the answer the same question for same questions? Or I think we are suffering in the same way, and we are worried for sustainability, and we are looking for lots of support, like here, committed people, and then different country has different problem. Right now we did lots of advocacy and introduction and meeting, even when Dr. Karen was with us, and we went to INGOs and big FAO, bigger organization, public health officer. There's a wonderful program. It's a really good program. And then after, they just forget. And it's very interesting. One of our chief public health director, and when we explain how we do the fluoride application to prevent the tooth decay, she said, I want to have that too. And we did apply. Then after, she never cares. Oh, we need funding first. So I think the problem is the same. But slow and steady, it will eventually reach this, and we can see the smiling face in the world.
Samson, you want to comment?
I think the best request we can make for the group is what my friends have just said, is commitment and having the passion to spread the smiles worldwide. Thank you.
Good. Other comments? Priyanka?
Hi, this question is for Samson. I'm curious to know, in a community, a rural community from like Maasai, where you're from, is there as much of an influx of junk food in a Western diet as we might see in the other countries that were presented, like Nepal and El Salvador? And if not, what is the community's perception of junk food, and how did you convince or educate them that it's going to have poor oral health and overall health outcomes?
Sure. To answer that, there's a challenge there because when the people go to the market, they will get a lot of junky foods to reward their kids since they've been away the whole day. They'll bring a lot of junky foods, and there's also shops. There are no centers. The households are the one which sell sweets to the kids. Have I answered you?
Yes, Saskia.
Yeah, I'd just like to echo a little bit because I think we heard 3 wonderful presentations. And what inspired me right now really, and I think, Karen, this is really a challenge, more so than oral health to nutritionists, I think. Mm-hmm. And just looking at the big picture, we have I'm going to stand up. We have new guidelines that the World Health Organization is about to make them public. And that is the reduction from 10% to 5% for free sugars. And if those guidelines can be implemented, I think the oral health definitely will benefit from that. So I think your programs will benefit from it, but the guidelines have to be implemented with the support of the ministries of public health, with the support of policymakers. So I think if we were to spend a lot of energy, because you're working at the community level and it's very focused, but if we want to make that more of a broader public health intervention, we have to look at the big picture. But what worries me also is that in some countries, the nutrition transition is just coming in. Mm-hmm. And that is very important. Because look at Mexico. It took a decade to go from, not so fat to being the fattest in the world. So I think that's something that we have to look at it. And the advocacy has to be towards nutrition. And oral health has to be aligned with those policies because we will benefit from that.
Right, great, thank you. Let's see, one more comment, question? Martin, do you want to go?
Yes, I would like to speak for children. If I were a child, which I was at one time, long time ago, I wouldn't care about sugar or whatever. I would care about having a toothache. And I think if we at least measure our success at that level, how many children have had a toothache or more than one toothache or no toothaches? Not caries-free even, just no toothache would be a good way to measure success because that's what the patient, that's what the parent cares about most. And if you can use that as your focus, not a cavity, just keeping the mouth from hurting as long as you can.
Good, thank you. I think that's a nice way to close this morning's session. I think all of us can say we believe in having a world in the future where children can grow up without having to suffer from mouth pain, without the mouth pain interfering with their ability to eat, to sleep, to grow, to develop. So that's what we're all going to commit ourselves to. Thank you. So now we have, let's take a 10-minute break, and then outside we have student posters that you'll be able to look at, talk to the students, ask them lots of questions about the work they're doing, and then we're going to come back and Dr. Habib Benzian will do the wrap-up presentation for the morning. Thank you.